Tired of dealing with vein disease? Have your symptoms gotten worse?
Oh, these spider veins are ugly.
My legs and ankles are always swollen.
My legs are tired of standing all day.
While some symptoms can be managed by lifestyle changes, other factors are out of your control. Get help from the experts at Vein Clinics of Hawaii. To learn more about your treatment options, call 427-5565 or visit veinclinicsofhawaii.com.
Aloha, Hawaii! It's time for the Vein Clinics of Hawaii radio show. Their team's approach to diagnosing problems and developing solutions and treatment plans are beyond compare. So let's get started with your host of the show, Mike Buck, and medical director, Dr. Randall Juleff of the Vein Clinics of Hawaii.
Well, hello there, and welcome to another one of our programs. You're going to like today, if you were with us last week or the week before, you heard one of our mailbag shows. We got another one. A lot of really neat stuff. And one of the things that we wanted to do is let you know that Vein Clinics of Hawaii, found on 4 islands here in Hawaii, started actually up on the Big Island. A couple of years ago, opened here on Oahu. And, you know, even every island is different, and yet every island is the same. And today, we got stuff, and this is really, really appropriate, where we get filtering in from all over the place is these different questions. And those of you that get online and Google this or Google that, we're going to save you a lot of time, because I got some great questions today for the doc. And if you want to submit one, we'll tell you how to do that later. We also want you to make a point to please go visit the website, learn a lot about things, and see some pictures. Hard me to show you the pictures on the radio, but we can sure show them to you on the web. That's veinclinicsofhawaii.com. Okay, so starting off with Doc today, and this is, we've all seen this. It says, my mother gets woken up constantly, constantly by muscle cramping, trolley horses, she calls them. Is it, it really is having a major effect on her ability to get a good night's sleep. What's that all about? Is there something can be done about this? And maybe what are the causes of it? That's a great question, isn't it?
You know, it is a very good question, because we hear that complaint all the time. Yeah. And you know, especially in the older age groups, this muscle cramping that people can have, especially in the middle of the night, it becomes tremendously disruptive.
Well, I must tell you, it's no coincidence, and you know, because not only am I a facilitator for the show, Doc, but I'm a patient, and it is something that I think, because of either dehydration and other vein issues that I had before I got treated this last go-around, was sometimes if I would point my toe down and, you know, stretch out in bed, get a cramp that was like really, really sore.
Right.
And you couldn't make go away. Thinking, what's going on here? Why did this thing wake me up? What is that?
Yeah.
Anyway.
Well, you know, it happens from a variety of different reasons. But yeah, in that, exactly what you just described is what we hear everybody say. Yeah. It happens at night, especially, or early morning. Yeah. When they're waking up and they try to stretch, and that's when, you know, that muscle, and it can be very, very painful. Yeah. I mean, it happens to me occasionally, and, you know, it's painful. And then in addition to that, it takes a while to get rid of it. And I think that's what, again, some of these older folks, you know, they're waking up in the middle of the night. They're having to deal with this cramp that could last, you know, 20, 30 minutes. And, you know, it takes a while for them to then walk around and, you know, try to relieve it.
And by the way, all the things that you think are going to relieve it don't. Yeah. And the things that you know you're supposed to do, you can't because it's too sore. It can be pretty frustrating.
Yeah. So, you know, what does muscle cramping do to? There's a variety of different things. You know, muscle overuse. You know, if you exercise real hard one day or for a couple days, and, you know, then maybe for the next several, you're going to be, you know, suffering with muscle cramping. Dehydration is another big one. And I think that probably most people that have kind of run-of-the-mill muscle cramping that isn't due to other things like vein problems, it's usually dehydration. Mm-hmm. So, the first thing we always tell people when they come in with muscle cramping is, or the first question that we ask them is, are you drinking plenty of fluids? Yeah, yeah. Are they the right kind of fluids? And we just kind of express how important good hydration is, not only for muscle cramping, but for a lot of things.
Yeah, well, how's this? I mean, some people will tell you, well, I don't want to drink anything before I go to bed because I'll have to get up and go to the bathroom all night long.
Right.
Oh, you really? Well, okay. This is a fine line you're walking on or not walking on.
Yeah, it is often a fine line, yeah. But, good hydration. And then also mineral depletion, especially potassium and magnesium in particular. And typically when people come into the office and they say, gee, I have bad muscle cramping, those are the two things I say, make sure you drink plenty of fluids and make sure that's a good quality kind of electrolyte, like Gatorade or whatever.
Sure.
Don't be afraid to drink, into the evening, even though it's going to be inconvenient for you with respect to that. But also, go to the drugstore and get a magnesium, bottle of magnesium.
Yeah.
And it doesn't have to be anything fancy. I get vitamins from Walmart. And, just take the magnesium as prescribed, as recommended on that bottle. And often that helps quite a bit. The good hydration and magnesium supplementation.
There are some things, though, Doc, and maybe you can explain that. And that is, if somebody says, well, I get a headache, I take an Excedrin. Yeah. And if I get a bad headache, I take 2. If I get a really bad one, I take 3. Aren't there some things that you can oversupplement, like potassium? You can. Yeah, you definitely can. Probably any vitamin is not good if you take too much. Yeah, there's no question about that. By the way, gang, one of the things that happens if you go to Vein Clinics of Hawaii, which I hope you do, is you're going to get the grill, I call it. It's not the hibachi grill. It's the iPad grill that you're going to get, which really is a deep dive into what you are. And I thought mine, for instance, was an eye-opener because I read some of the questions and I didn't really connect some of the things that I was taking that now and I know that I am taking that might have been working against each other.
Right.
This can happen.
Oh, yeah.
Like we talked in a previous show about an aspirin regimen. And sometimes if you go to a doctor and say, list all the things you take, well, you take the aspirin for so long, you forget you take it.
Sure.
And all of a sudden now you've answered the question incorrectly.
It's a little tedious to write all that stuff down, but it is good to review those things for yourself every now and then so that you can kind of keep track of exactly what you're doing and discuss things that you have questions about with your physician. Make sure you still need them, So the next big reason why people might have muscle cramping is venous insufficiency, and just over the years that I've been treating venous insufficiency, I've been really pleasantly surprised, really, about how well muscle cramping can be positively affected by treating people's vein disease.
Wow, that's so good to know.
And again, with the older age group, who really their quality of life is really impacted by getting up once or twice a night, being awake for an hour, trying to get rid of a cramp, and if you can get them to a point where they're not waking up, maybe they might have an occasional cramp or whatever. It makes a tremendous difference in their quality of life, and it's been great seeing that. Because some people come in. And cramping is one of those symptoms of venous insufficiency that most people don't know about. Most people do not connect muscle cramping with, maybe I might have a vein problem. Nobody says that.
Exactly. That's the line that it's probably not typical that people draw.
Yeah, exactly. And like we've talked about before, there's a bunch of symptoms that go along with venous insufficiency that aren't, obviously connected, and people don't know, so that's why we do this kind of stuff, to try to educate people. But venous insufficiency is absolutely a potential cause for muscle cramping, and it's just so good to be able to see it being relieved once we treat those people. So, and there are other, the risk factors for muscle cramping is age. I think, so that, again, that older age group, they're experiencing more muscle cramping, pregnancy, other medical conditions. So, there are other reasons why, other than just venous insufficiency, but often venous insufficiency can be a part of that picture.
Well, one thing that I've learned, gang, since we first started doing the program, and that is that there are a myriad of symptoms that can be, attributable to venous insufficiency. And I do know that there's a specific process of elimination that you go through. But isn't it amazing how most patients have several things that are in common, and they just maybe don't relate that to venous insufficiency or even their legs?
Yeah. We see that all the time. And it's unfortunate, but we try to do our part in trying to help people understand the connection.
Yeah. Well, when somebody says, "Look, I haven't walked for a long time," and I went for a long walk, and boy, my legs are so sore today. I guess walking's no good for me.
Yeah.
And when, in fact, I'm worried that maybe some people, some of our tutus and things would think, I don't want to lie down because if I lie down, my legs are going to get crampy. So I'm going to stay here in my rocking chair.
Yeah.
We have people whose actually quality of life suffers because they are afraid of a leg cramp.
Sure. Oh, absolutely.
That's a horrible thing to think. Gee, I wonder if I'm going to get a leg cramp tonight.
Right.
Yeah.
Right. Yeah, and that's exactly the people that I'm talking about. So when do you consider, somebody who's suffering from muscle cramping? Who are those people that should be a little more concerned about entertaining the idea that maybe it has to do with their vein function? If you have any other symptoms that might be related to venous disease, then obviously you're going to want to come in and have us take a look at it. What are those other things? Well, the other things that are most common with venous insufficiency.
When somebody's not having a leg cramp,
is
there any way you can tell that they're going to get one? In other words, there's nothing there. For instance, when you talk about one of the diagnostic pieces of equipment, which we talk about all the time, and ultrasound, can ultrasound help in finding out if somebody's going to have a leg cramp, or is a leg cramp a symptom that ultrasound better be looking for something else?
The ultrasound is going to tell us if their vascular system has something to do with their symptoms. Is there anything specific about what we see on the ultrasound or any other diagnostic test that we can say, oh, yeah, this patient, has muscle cramping as part of their history. It is due to this. Unfortunately, no.
Yeah, because I'm guessing that some people, they could bring on a leg cramp just by the way if they're prone to have them all the time. If you point your toes in that direction, you get a leg cramp. Well, don't point your toes in that direction.
Right.
But still, it's still there, isn't it?
Sure.
So, whatever is the underlying issue of why it's caused it still needs looking at.
Absolutely. Yeah. Absolutely. So, and some of our happiest patients are those people that we relieve from muscle cramping, because again, it is just such a huge factor of just general quality of life. A good night's sleep is way up there.
Amen. Okay, I really love this next question, gang. And by the way, you go to veinclinicsofhawaii.com and see all the things we're talking about with pictures. But this one I really like, because everybody, you say, well, we're just, our whole family, we're just a big family. And so here's a great question. Everyone in my family has big legs. I've always thought that it was just genetics, but is there something else going on? Boy, that's a great one, because I know that there's big and there's big, and why did some people have big legs? What is a big leg anyway?
Well, I think the thing that this question goes to is that person's big leg? He's saying big leg, but does he really mean swelling?
Yeah, that's what I'm asking.
And that might be seen in a number of his family members, and it may not just be because it's a genetic predisposition for that family to be overall big.
Isn't it sort of interesting? And I see this in we're an outdoor state. Everybody we're always outdoors. There are one friend of mine says, I got the and he used his last name. I won't use the last name, but I got the so and so butt.
Yeah.
Because everybody in that family is large. They're not obese. They're not overweight. Their upper body looks totally normal, but they just have big hips or big butt or big legs.
Yeah.
It's interesting, isn't it?
Oh yeah. And that's for sure. I mean, there can be genetic traits of their overall body habitus that is passed down from one generation to the next. Each individual person has to kind of have a reality check. Is this just a big leg, or do I have swelling? And which is a good question.
Yeah.
I mean, how do you know whether you have swelling or not? Well, one of the things that we do when we're just kind of doing an examination of a patient is we will press on their leg, especially over the bone, the front bone of the calf. If you press, the flesh in that area, and if you see an indentation of your finger.
I do it every day just to make sure that I've not got edema or not swollen. Yeah.
And if you form an indentation when you're pressing on that bone in your leg, and the indentation stays there after you take your finger off, then
not good. Not good.
You have swelling. You have edema.
Yeah. But if you have a big leg, and you press, the minute you let go, boom, the skin's back up there again.
Yeah.
That's okay then.
Probably okay. Yeah, probably okay. So that's a pretty simple thing that you can do to determine whether you have swelling or not. Now, what are the reasons for swelling? Well, swelling does go along. Swelling is one of the signs and symptoms of chronic venous insufficiency.
Okay.
We see it all the time. And, we were speaking before about the clinical classifications of venous disease, and swelling is a third level. We call it C3 clinical classification. It's again very, very common in the patients that we treat. But are there other reasons? Yes, for sure. There's swelling that might go along with other chronic medical conditions like poor heart function, for instance, fluid and electrolyte abnormalities. And then, of course, the thing that we see the most of that kind of goes hand in hand with venous insufficiency is something that we call lymphedema. And lymphedema has to do more so with what we call the lymphatic system. The lymphatic system has to do with just the movement of clear fluid through our body. And sometimes the lymphatic system isn't working. Also, similar to the venous function, it can be abnormal, and so you get a buildup of fluid.
Here's the reason I wanted to ask one more question on that line, and that is, people don't really understand. I've been learning since we did the program and since I'm a patient that there's a lot of things going on in our legs that are occluded to our ability to see. It's called skin. Yeah. And, you can't see through it all.
Right.
But there's several different systems there that are all moving around different sorts of liquid. And, obviously, does one beget another? In other words, if you've got something wrong with one system, is there a probability that sooner or later you're going to have something wrong with some of the other systems? Not just because they operate in the same space, but because basically they're doing similar functions.
Similar functions, but probably also because they're operating in the same space. I mean, I think that's a good description. And we have found, just from experience that, lymphedema and venous insufficiency very much so go hand in hand, especially in the setting of people who are carrying a little bit too much weight. Obesity
which unfortunately here in Hawaii happens to be a lot of us.
Well, all over the country.
Of course.
Especially in the obese, lymphedema can be a big part of it, but again, it often goes hand in hand with venous insufficiency. So, when people come in, or if people have swelling that has not been defined otherwise, we're talking about fairly active people who don't have a lot of other medical problems, which would be, other reasons why they might be collecting fluid in their lower extremities. If they don't have those things, then very likely they do have venous insufficiency. Yeah. So, it certainly would warrant an evaluation. And again, if somebody comes in with swelling, we do a venous or a venous ultrasound, define their venous function, and then try to do something about that if it's warranted.
Yeah, pretty fascinating. If you ever have the opportunity of having one of these ultrasound treatments, or ultrasound. I don't know if it's a treatment, a diagnosis.
Yeah.
It's fascinating how the operator and at Dr. Juleff's office, the ones I'm talking to every time I'm there, it's amazing what they can show you as to, okay, if you are inquiring minds want to know, this is this and this is that. Mm-hmm. It's spectacularly interesting to me as a patient, knowing that I'm having this equipment being able to be used on me. It's to say, wow, this is like, it tells you so many answers to so many questions, doesn't it?
Yeah. It's a tremendous tool, but in patients do like to see it. Mike, who is our vascular tech there, enjoys kind of showing people what he's doing and what he's looking at. And it's not that difficult for a patient to kind of, look at the screen and to sort of see, what's going on. And it's fun. People have a fun time seeing that.
It is fun. And there's also a sound effect package.
Yeah, right.
And that is like, so you can hear the squishing and the squashing, which it's fascinating what's going on in there. But what's specifically fascinating is and by the way, the ultrasound treatment is painless. I mean, every now and again, I guess the probe might be a little bit sort of depending on what result or what test it was being. But you can lay there and have a half an hour ultrasound, treatment, and it's no problem.
Yeah, you could take a nap.
You learn a lot. Yeah, you can learn. But it's particularly when you say, okay, now bear down.
Yeah.
And then you can feel this release and you can see this stuff.
Right.
Isn't that fascinating? I mean, I'm fascinated by it.
Yeah. And I think most patients are. They many of them come back and they say, gee, Mike showed me this or that. And, fun. It's fun seeing what's going on inside your body. Yeah. It's a fun thing.
Is this, by the way, this is one of my many sidebar questions. I do know that during procedures, quite often you will employ the ultrasound as you go along. Mm-hmm. Isn't that a neat accompaniment to the surgeon to know that, okay, it's not just my expertise here. Here we got the machine. Show me this and show me that.
Yeah. Well, not only that, but also we use the ultrasound machine extensively just to do the procedure.
Yeah, exactly.
To be able to see what we need to see to make the procedure happen the way we want it to. And that has been a tremendous tool also. Much different from years ago when we didn't when it was things were a little more rudimentary. But when people come in with swelling, we do a venous ultrasound. We find out if they do have venous insufficiency. Now, if the cause of their swelling is more than just venous insufficiency, do we throw up our hands and say, well, there's nothing we can do? No,
you're going to go. That's next step. What's the next step?
Yeah, so typically we will fix their venous disease. We'll do whatever we normally do to treat whatever venous reflux they have. Now, is that going to eliminate absolutely all of their swelling? Well, often it does not. But what we're hoping for is that it's going to have some substantial amount of relief of their swelling, and we want to optimize the overall. You mentioned the fact that there's a lot of stuff going on in our legs, and there is a number of different systems, and we want to make each of those systems as optimally functioning as we possibly can, and that's why we treat their venous disease, even though they may be left with a little bit of swelling from lymphedema if they have it. Lymphedema is something that unfortunately is not remedied as easily as we can remedy venous insufficiency, but there are ways to deal with it.
Yeah, and I'm glad you said that. And gang, here is sometimes, depending on how ill you are, whether it's venous insufficiency or if you're obese or if you're diabetic, sometimes if you get fixed or cured or helped, you've already done some damage that might be irreparable. For instance, I have a lymphedema situation in me because of being in bad shape for so long that is, I'm certainly not adding to it anymore, but it's not going to go away. In other words, there's some things that's the price you pay for doing what you did.
Yeah.
You know?
Yeah. And not only that, but, lymphedema can be a result of surgery or of radiation therapy, a bunch of different things. So, and unfortunately, no, once the damage is done, it probably is not going to get better. But that is not to say that there aren't ways for us to remedy the swelling. There are, mechanical type things like compression stockings and other things that help us.
Okay, here, I love this one. Coming up on our next mailbag question, this is a neat one because I know this happens an awful lot. A lot of my friends have asked me since they've heard me doing the show, should I go see the doc? Should I go see the doc? This is a great question. It says, all I have are spider veins. Do I have a medical problem, or is this just cosmetic? Boy, that's one short question, which probably is a nice long answer. Yeah. What's the deal? What's the deal on that?
Well,
is it likely that I have a medical problem?
It's a possibility. The spider veins are just one component of the entire venous system of our legs.
Yeah.
The veins in our legs are kind of like a big tree root. Where the deepest main veins are like the trunk, but then you've got all sorts of generations of smaller and smaller venous kind of branches that then move up more toward the surface, and then once you get to the level of the skin, spider veins are tiny. They're the tiniest little branches of that root. So why do we start to, at some point in our life, start to see spider veins? Is it part of a bigger problem, or is it just we got spider veins? Well, it could be either. And it's sort of, in my experience, it's kind of 50-50. I mean, some people.
And by the way, that would mean, unlike a lot of other surveys, that's a lot of patients. When you say 50-50, you're talking about lots and lots of people here.
Yeah, well, there's a lot of people out there with venous insufficiency. Sure. So there's a good number of those people who have spider veins. But again, there's a good number of people who have spider veins and do not have an underlying medical problem like venous insufficiency. So, what are some of the what are some of the questions that we ask ourselves if a patient comes in with spider veins and says, what do I need to do? Should it be treated? Do I have to worry about something else? Well, then we ask them some questions. And basically those have to do with the other symptoms that might go along with venous insufficiency. Sure. Because the other thing you have to keep in mind is that, people with just spider veins might have venous insufficiency. Some people with venous insufficiency have perfectly normal looking legs. They just have other symptoms.
I was going to say, isn't that interesting when you find somebody that doesn't have spider legs, spider veins, but they have venous insufficiency? Sure. They're going to need procedure. You can't see it, but it's there.
Yeah. Spider veins. They may not have spider veins, may not have varicose veins. May not have swelling, but maybe they have achiness and fatigue. As they stand throughout the day. Maybe they have muscle cramping, as we talked about before. Maybe they have something called restless leg syndrome, which we're, I think, going to talk about in a minute. But all of those symptoms may be caused by venous insufficiency that you don't see superficially. So we kind of go through that. We ask the patient questions about whether they might have symptoms of venous insufficiency. Some of them do not. Some of them say, "Hey, no, my legs feel great. There's no problem." And then often we just go about treating their spider veins. For us, the main question is, should we do an ultrasound? And, because the ultrasound is a thing that tells us whether the patient has venous insufficiency or not. And so we are directed by their symptoms, and if they have some symptoms of venous insufficiency, or if they have symptoms that may be suspicious for venous insufficiency, then we say, let's do an ultrasound and find out. Way,
on the subject of the ultrasound, real quickly, because we've talked in previous programs that sometimes certain parts of what you do at Vein Clinics of Hawaii are called elective surgery, like spider vein removal or treatment, because it's not, I guess, by the insurance companies don't think it's health threatening or urgent. It's something that's cosmetic. But I would imagine on the other side of it, when it comes time to get a patient approval for a procedure, whatever, that backing it up with ultrasound tests.
Oh yeah,
are helpful to the insurance company.
Oh yeah, well, imperative. They want to know that we did an ultrasound and showed reflux, and more importantly, or as importantly, they want to make sure that they ask us what are the symptoms, and we want to know that too, because some people may have a modicum of, they might have venous insufficiency, but it's not a lot. Yeah. And if they're not having symptoms, then typically we don't treat those people for their venous reflux. Okay. Now, we might inject their spider veins if they want us to, but we, sometimes we follow, venous insufficiency if it's minimal and the patient is not having symptoms, which is, that's the appropriate way to treat those people. And we follow them over time. And then at some point in the future, if they develop venous insufficiency that is symptomatic and is more significant, then we might recommend that we do intervention for that. But so the first question is, does the patient need an ultrasound? Second is, if they do have venous insufficiency, are we going to treat it or not? Sometimes we do, sometimes we don't. And then, eventually we get to...
By the way, I'm really glad you said that, because I remember many programs ago you said this. And I mean, just because you discover venous insufficiency, there are plans and ways that you can sort of say, well, as far as the big picture, that's not an urgent thing right this minute, because it's not really threatening you other than being a little bit symptomatic. But this other one, where you have a clot, that might be a little bit more urgent, urgent to look at. Oh, yeah. Doesn't that give you, though, as a patient and as a doctor, a lot of flexibility as to working out what's the best plan of treatment for whatever's going on there?
Right. Yeah. And that's the reason why we do an ultrasound in those people, to help with that question. What do they have? And is it something that we should do something about as a first step before we do other things? For instance, treating spider veins. Yeah. If the patient has, along those lines, if the patient does have significant venous insufficiency and they have symptoms that are going along with that and they, want us to treat that, then typically the most medically correct way to do that is to treat their venous insufficiency first. We eliminate that underlying problem or that underlying reason, and then we move on to the more superficial stuff. So then we treat spider veins. Pretty interesting. And by the way, gang, I don't know about what you would do as a patient, but I know what I do as a patient is make sure that I have a regular visit. A dermatologist might tell you, take a look at your birthday suit on your birthday. And I'm guessing that what's recommended for me anyway, and I would imagine most of your patients, is that you should have an ultrasound done probably at least annually, so that you can see, because you talk about the records that you keep. Here's my leg then, and you can give me an ultrasound now, and I can see as a patient, it's either stayed the same or it's changed or it's gotten to a point where it needs treatment. Right. That's really encouraging to a patient to know that there are all of these factoids that you can get to help make your decision. Sure. Yeah. Because of the fact that venous insufficiency most often is a genetically predetermined kind of problem, we're not changing that. Yeah. We're just treating the problems that the patient has at that particular time. So there's, even when we fix the problems at one point, those genetic factors still continue, obviously. Sure. And that's why we do what we call surveillance ultrasounds for our patients. And typically it's an annual kind of thing. And gang, the reason why I said that is because we're talking about lifestyle here and enjoyment of life and quality of life. So what the treatment plan does is give you that. So quite often, and this is another neat question that I think is really neat. Quite often, you hear about, and I don't know exactly what it is, but this thing you call restless leg syndrome. And I thought that was the guy that was sitting there and his legs just jumping up and down. Yeah. And in some respects it is, but when you're talking about that, aren't you talking about something that usually happens when you're in bed? Yes and no.
Yeah.
But yeah, it's not the person who has the nervous leg,
the nervous tick or whatever,
like little kids.
Yeah.
But restless leg is it's a medical condition, and it takes on a number of different forms. I think that in its worst form, or its most significant form, people can actually have involuntary movement of their legs. At night when they're sleeping, that actually wakes them up.
Yeah, I was going to ask about that. That's what I've heard. Yeah.
And I think that's the typical description that most people talk about when they talk about restless leg. But in addition to that, restless leg could be as simple as the not involuntary, but kind of the unconscious movement of our legs and feet, even when we're awake. You see some people when they're just, sitting at a desk or whatever, and it's not a kicky kind of thing. It's just they're moving their legs and their ankles and their feet. Now, why are they doing that? Well, they're doing that because, as it relates to venous insufficiency, basically what they're doing is that they're contracting their muscles. And when we contract our muscles, that muscular activity augments venous flow. So, there's something in our leg called the calf muscle pump. And, like we've talked about before, blood moves through arteries because the heart is pumping.
Like a faucet, like a hose.
Yeah,
right?
like a hose. Yeah. And, there's one heart and then all of our arteries come out of that. Well, on the way back, it's not like there's thousands of little hearts down there pumping, blood through the veins. It relies on, other muscular activity, and that's why we call that the calf muscle pump, because that's the most, I think, probably significant area of our leg where muscular contraction is going to lead then to blood flowing through veins in a normal fashion.
Is some of that stuff is just normal? Almost, just normal activity. Like all of a sudden somebody says, I got to go put my legs up. We know what we need to do.
Right.
In other words, some of this stuff I'm guessing could be, this is coming on. I'm going to go elevate my leg or go get a glass of water or do whatever.
Yeah. Well, it's kind of, they've learned those things.
Yeah.
I mean, a lot of our patients who have bad venous insufficiency, one of the questions that we ask is, do you elevate your legs? And, people don't necessarily know why they want to do that, but at the end of the day, they come home, their legs are tired, achy, etc. And, the first thing they want to do is lay down on a couch and elevate their legs because it makes their legs feel better.
I've heard so many people say this, and I always get a kick out of the phrases, hey, come on, come take a load off, sit down. And that means really, it's true, isn't it?
Oh,
I mean, if your legs hurt, sit down. But I do know that there's some people when they say hurt, they really hurt.
Oh yeah,
it's lifestyle threatening.
Mm-hmm. When we talk to our patients with vein disease, I mean, so many of them by the end of the day. After a long day of work, especially if they're working on their feet, their legs feel terrible, and they have learned, and they probably don't even know why that's happening, but they lay down and their legs feel better, and then they can kind of go on with their evening. But restless leg syndrome, it affects about 10% of the American population. It's a little more frequent in women, and it can be due to venous insufficiency. Typically what we say is that it's about 45% or so of people with restless leg syndrome. The cause of it is venous insufficiency. But that's kind of the statistical number that's out there. But I got to tell you, just from my experience treating people in the vein clinic, the people who have venous insufficiency, it almost always affects their restless leg in a positive sort of fashion to one extent or another. Now, sometimes it doesn't eliminate it completely after we treat them. Sometimes they're still left with a little bit of restless leg, but often it has a fairly significant effect.
Interesting. This is very interesting. And let me ask you this as a doctor, and I know because you deal with so many patients. This one guy discovered a way to reduce his migraine headaches by 50%. And you think, well, why should he be excited about that? Well, because he reduced his migraine, because it was a huge improvement.
Right.
In other words, he used to get a migraine every 3 days. Now maybe he gets them once a week, and they're not as severe. This guy has made major strides in the right direction.
Sure.
Right? Same thing with this.
You're right. Sometimes we don't eliminate a symptom completely, but as long as we eliminate it to to a fairly substantial extent, the patient is happy, and I would be too.
Yeah, I mean, it boils down to quality of life, particularly as we get older. Let's say if you're a grandparent, wanting to go to your kid's soccer game, and if you have to walk along a country mile and then sit on some rocks, you're like, I'm not going to that. It hurts my legs.
Yeah. So what are some of the other causes for restless leg? Well, there's other medical conditions. There's a little higher incidence of restless leg in diabetes. Anemia can lead to restless leg. Parkinson's disease actually is one of those, neurologic kind of things that is connected with restless leg. Alcohol, caffeine, nicotine, all those things that we shouldn't be using anyway. And then some medications. So there's a variety of other reasons other than just venous insufficiency why people might have restless leg. There's a medication called Requip. Requip, yeah, and there's some marketing for Requip on TV periodically. So I think that's one of the more common oral medications that may be started for patients with restless leg syndrome. And then there's other medications, various sedation kind of medications. There are some anti-seizure medications that people will actually resort to treat restless leg if it's severe. But again, it's good if you have restless leg. That's one of those symptoms that people typically do not connect with a vein problem. If you have it, then it's worth finding out about it and finding out if you do have a vein reason to have that.
That's very interesting. And gang, one of the other things we talk about, why you want to go to veinclinicsofhawaii.com and take a look at some of these things that we're talking about is that. I think that there's so many things, like I said earlier when I asked Dr. Juleff about all of the things that are going on in that leg that you can't see. And that means that there's an awful lot of symptoms that you have to go through a symptomatic, process
checklist.
of elimination. Yeah, checklist, it's like a punch list. Whether you see your dermatologist, your diabetes guy, your cardiologist, your vein surgeon. I mean, there's so many of these symptoms, right?
Sure.
That lean on each other, and you have to be like a detective there.
Yeah, and sometimes you have to do studies or tests or whatever to show that a patient doesn't have something. For instance, if somebody comes in with restless leg, we do an ultrasound, and what we're basically doing is showing possibly that they don't have venous insufficiency, so we can check that off as a potential cause for restless leg.
And each specialist along the line is grateful to know that the other guy's specialty has been eliminated.
Right. Right. Yeah, we run into that scenario all the time.
Sure.
Yeah, sure.
Okay, now here's another one. This is a very, very common one, and I think this is very interesting. And by the way, if you ever have a question, you just go to veinclinicsofhawaii.com and submit it, and you'll get on one of these lists one of these days. I have seen this. I've been a patient of this. I know a little bit about it. Doc knows a lot about it. And this question is really interesting. I have a sore on my ankle that does not seem to want to heal. Why is this happening? And that when you say sore, aren't we going to talk about what you call ulcers?
Yes.
Leg ulcers.
Yeah.
Boy, I don't know what percentage of people suffer from that, but I do know that it can be a real, excuse the expression, real pain in the leg.
Yeah.
And other places.
Yeah, it can be a common problem. I mean, I'm always surprised at how many people do have ulcers, and we see a lot of them in our line of business. But are there other? There are other reasons why people have chronic ulceration, for one reason or another. But the usual causes are either arterial,
artery,
which has to do with which has to do with the blood flow getting down there. So if a person is lacking in the amount of arterial blood flow getting down to their lower legs, then we're talking about too little oxygen getting to an ulcer. And can that be a reason why that ulcer has formed and is not healing? Yes. So we think about our arterial insufficiency. There's another type of ulcer that we commonly refer to as a diabetic ulcer. And diabetic ulcers are obviously occur in people with diabetes. They're often more on the bottom of the foot. They often arise from an injury to the foot, or start because of the fact that many people with diabetes have this neuropathy, and they can't feel.
Yeah, they're numb.
The bottom of the foot is numb, and they don't understand that they've got a little stone in their shoe, or they've injured their foot. So those are diabetic ulcers. And then there are something called venous stasis ulcers, which obviously are the ones that we deal with most of the time. Those are the three main ones. Now, there can be other reasons: traumatic ulcers, inflammatory ulcers, malignant ulcers. Sometimes people will have skin cancer, and that turns into something that looks like an ulcer, and it's also going to go through a non-healing sort of process, and we have to figure out what that's all about. But
I must tell you, though, and gang, once again, as you know, not only do I host a show for Doc so that we can get the word out, but I'm a patient. And I have had this ulcer situation, certainly not as bad as some others, and I've seen how severe they have. And once you know where you are, it's easier to sort of accept what it is. I'm not sure that you can really prevent them because, it's not something you say, well, I drink orange juice, so I won't get a leg ulcer.
Right.
But it does mean that if you treat it as an ulcer quickly, the problem doesn't seem to get it as bad as some of these things that we've seen.
Yeah. Well,
is that a weird way to ask?
Yeah. Well, what I think you're saying is the important thing is to figure out what the cause is, and then to do something to correct that cause, to correct the underlying reason that patient has an ulcer. Now, getting back to what you first said, often there's no way to avoid it, and often there isn't, because sometimes arterial disease or diabetic disease, etc., doesn't become apparent until they have something like that, until they develop an ulcer. Maybe that's the first symptom that they had.
Can they just pop open on their own, or do they take a hit from outside to happen?
Well, both. I think that especially with diabetic ulcers and venous ulcers, often they're initiated by some sort of trauma to the skin. Arterial ulcers will often happen just spontaneously because of the lack of blood flow, but they can also be initiated by some type of injury. So what is the most common cause for ulcerations? And actually, it is venous ulcer. A venous insufficiency is the most common cause for ulcers in the lower leg, around the lower legs and feet. If we've talked periodically about wound care centers, and there's a bunch of wound care centers these days, and they do a great job because they concentrate on healing ulcers and wounds of a variety of different types. But if you look at all of the lower leg ulcers, or the leg, the lower extremity ulcers in a wound care center, about 70% of those are due to venous insufficiency. So Again, venous insufficiency is the most common, and it's a huge reason why people might develop chronic ulcerations that don't heal.
And if you go to the website and see some of these pictures, they are incredible. And I never really thought about this until just now, because when you said some of these ulcers in plural, I'm guessing that it's common that people have more than one ulcer.
It's not uncommon.
Yeah. I was going to say, but most of the time, they're independent of one another, are they not? In other words, whatever made this ulcer, I'm going to treat this and we can make this heal, but the one on the other side of the leg is not going to get healed at the same time unless it gets treated.
That's true, but it's usually one reason or another.
Mm-hmm,
If it's not unusual for venous ulcers, in any one particular patient for that patient to have more than one, and they're going to be in different locations, but all of those locations are still caused from their venous insufficiency.
Well, you can get a diabetic ulcer in your foot, and then in your calf you can get a venous ulcer. Some people are that lucky. Yeah. Jeez, I guess.
But most of the time, it's either one or the other.
Mm.
Sometimes we see arterial insufficiency right along with venous insufficiency, and we have to kind of figure out what is the primary cause.
What is it here?
But surprisingly, it's not. That's fairly uncommon. And again, this has been kind of surprising to me over the course of the years that I've been treating this kind of stuff, is that usually it's either one or the other. I mean, if people who have arterial disease, typically they don't have also venous disease, and vice versa. Mm-hmm. So, that makes our job a little better, but sometimes we do run into people who have both. And typically we try to correct the arterial insufficiency first, because of the things that we have to do then to correct their venous insufficiency. We have to, go through skin and make, puncture site, et cetera. And if they don't have adequate arterial circulation, then those areas may become a problem.
Is there a measuring stick that you can use on an ulcer to determine when you should have it looked at? In other words, if you've got a hole, if you put a Band-Aid over it and 2 days later the hole's healed and you don't need the Band-Aid, obviously, you're okay.
Yeah.
But, I know that some people have a problem with the leg ulcer. It's for months. It's a long time.
Yeah.
So...
Well, that's a good question. That's a very good question. And I would say that, the parameter that I would use would be 1 to 2 weeks. Mm-hmm. Now, depending on the size of the sore that you're dealing with or the ulcer, would you expect something to be completely healed in 2 weeks? No. But if over the course of 1 to 2 weeks, if you're not seeing things that to you look like the ulcer or the injury is moving in the right direction, at least staying the same and slowly getting better, then past a couple of weeks, then probably you need to be concerned and have it looked at. If over 2 weeks all you see is that thing getting worse, then of course you need to have it looked at.
When there's two things to do with healing, right? It's healing from the outside and healing from the inside. Does it sometimes take a procedure to get rid of an ulcer other than just bandages?
Well, if it's due to, we want to address whatever the underlying cause is.
Sure.
So if this is a ulcer that's related to their venous disease, then we have to address their venous insufficiency. And in particular with venous ulcers, as we've talked about, often that's due to a specific type of vein anatomically.
Okay.
And that's what we call a perforator vein. Those are the veins that go sideways. And often people with venous ulcers have an associated perforator vein. And we have to make sure, number one, that we have defined that vein and define the fact that it's not functioning properly, which requires us to be doing a good quality ultrasound.
Sure.
And then also it has to in general be a part of our treatment plan to fix the reflux within that perforator, which often we don't do in other people, but in someone with an ulcer we're going to do that as sort of a first line therapy.
Yeah, I think, gang, if your takeaway from today's program, which is just about to end, is that, look, if you got any of these symptoms, that we've talked about, and particularly if you have more than one, it's time for you to take a look. I want you to go to veinclinicsofhawaii.com, veinclinicsofhawaii.com, and take a really good look at this. And I'm telling you, the path to healing is a wonderful path. And your symptoms disappear. You start feeling a little bit better. Your spiral of activity goes up instead of down. It's a pretty good feeling. We hope that you've enjoyed the program. We'd like you to come back again next time. In the meantime, go to veinclinicsofhawaii.com. That's veinclinicsofhawaii.com, and we'll see what we can do for you, all right? Have a terrific time. For Dr. Juleff and everybody at the Vein Clinics of Hawaii, I'm Mike Buck. We'll see you next time.
Well, that's our program for today, and we certainly hope you enjoyed meeting us. Please come back next week for our next episode. And in the meanwhile, to learn more, please visit our interactive website, veinclinicsofhawaii.com. That's veinclinicsofhawaii.com.